to invite Professor Quirke to the podium from the University of Leeds. Professor Quirke is the head of pathology and biology, who will give us some talk about macro and micro assessment of the specimen after a surgery by the
So, thank you very much. Last time you have to hear from me. My thoughts on lymph nodes are that actually big lymph nodes are good for you because they demonstrate a sustained good immune response. And so if you're uncertain about what's going on out in the pelvis, just actually look in the rectum and see whether there are significantly large lymph nodes in the rectum, and then you're most probably in the context of a very good immune response going on, and that's positive. Or you've got a really awful situation that all the lymph nodes are totally replaced, and if that's the case, well, you've got a big problem. There's nothing you can do about it. The other side is, of course, that if Gina was here, she would say it's the texture of the lymph nodes and not the size. So be careful of lymph nodes, and lots of lymph nodes is good for you. You've just heard from a surgeon talking about radiology. You're now going to hear about a pathologist, what they think about radiology and how the pathology fits in. And I have to apologise that I may overlap a bit with Torbjörn, who'll be talking about abdominoperineals, etc., but I'm sure that you'll believe a surgeon when they talk about abdominoperineals. So if you don't like what I'm saying, listen to Torbjörn tomorrow and he'll give you the true story that you can believe. Having said that, I'm going to talk a little bit about the history background. We've got lots of youngsters, so I'll just go back 30 years for a few minutes, talk about mercury and mercury 1, mercury 2, and then just very briefly on microscopy, and I've shortened the talk in order to enable you all to get home this evening before midnight. So, if we move on, interesting, maybe not, there we go, sorry, it's, that's me a long time ago, and this video may not work, no it isn't working, which is a shame. That's me in the Karolinska doing a cut-up, and there's Lennart Blomqvist in the background, and Lennart was the person who first did MRI of specimens, and this was a specimen he'd done the MRI on, and we were able to demonstrate the value of pathology and radiology, and it all turned into Lennart and then subsequently Gina and Regina showing us how we should be doing these sorts of things, leading to a major change in management. And we can see that the margin is involved there, and you can see the histology. There's very good close associations between the pathology and the radiology, and that's been a lot of fun over the years. And way back when Bill's in the audience, we had the first mercury study funded by Pelican and Bill's charity, and you can see that there's Gina standing there amongst the team. And from this study of MRI and margins, we got a lot of information about where we are today. Now, Bill started with his papers in 82 and 86. I came along, here's the paper in 86. And what we were able to demonstrate is that with conventional surgery, you had involved margins. And when I first saw Bill's specimen at this meeting in Norway in 1993, you could see that actually he had completely different resection margins and completely different operative specimens to what I'd been used to. And so we saw that actually circumferential resection margins and plane of resection were linked. And we went on to develop this cross-sectional method of looking at the specimens, and demonstrated that this was reproducible and was able to demonstrate very high rates of local recurrence and very poor survivals. And then moving on from that to showing that as you reduce margin positivity, you're able to increase the survival curves of our local surgeons in Leeds. And even just, this is a lovely example of Bill going to Perth, and this was the specimen before Bill gave his talk and did his operation, and this was the specimen after, showing totally different quality specimens, a torn to pieces specimen with an involved margin, and a beautiful specimen done by the same surgeon, just after they'd been shown how to do it in a proper TME exercise. So we now know that you should be looking at the cross sections of the specimens, and you can see these very torn ones where the tumour comes onto the margin, and the much better total mesorectal excisions that will give you a much lower rate of margin involvement. And of course, we went on to develop a grading system of intramesorectal, muscularis propria, intramesorectal, there's a bit missing there, and then the beautiful mesorectal specimen here. So it's today margins and quality of the resected specimen. Now there is a rotating specimen here showing all these little fragments out in the mesorectum that you have to actually be certain to remove along with the primary tumour, and you can do that by following those mesorectal planes as nicely as you possibly can. And then making certain that you do not actually cut through and cone that specimen, and that you're coming to the end a good distance past that tumour when necessary, and then cutting straight across rather than coming across at an angle in order to get a clean resection of that specimen. Now where we are today is that we have a number of series here where we have reported the quality of surgery. And what's really heartening is we're going up from the old days of the Dutch TME and MRC CR07, where only half of the specimens were mesorectal, but that again was much better than it was way back in the 80s and early 90s, through to now between 75 and 80 to 90% of cases actually being mesorectal, with a concomitant reduction in the intramesorectals and the muscularis proprias. So this is very positive. Where can you get to? Well, we have claims in the literature of 99%. I'm very pleased it's not 100%, but 99%. Now, I've seen Kenneth Smed's, one or two of Kenneth Smed's specimens, and they were very good, but I haven't seen them all, so I can't vouch for either of these individuals. What we do tend to find in practice is that some pathologists are much nicer than others. Nick and I are quite unpleasant, really, and we tend to be quite harsh on our surgical colleagues. Sometimes people aren't harsh enough, so I don't know whether this is actually true, but I'm sure that actually they're at least here and they're trying to be perfectionists, which is very good. Now, you can see that concentrating on the margins over many years is actually a good thing. So even in Mercury 1, where we'd taken surgeons and we'd had meetings with surgeons, pathologists, radiologists, and we put emphasis on quality, we only got 63% of the low rectal cancers in Mercury 1 with a mesorectal excision. That's because low rectal cancer is the most difficult. Now, when we embarked upon Mercury 2, which was set up by Brendan Moran, Bill, Pelican Centre, Gina, we concentrated on the 0 to 6 centimetres, and what we were able to do there was to achieve an 80%, 79% mesorectal excision rate in Mercury 2. So concentrating on that low rectal cancer seemed to improve the resection rates, which was excellent. Now, does it matter which technique you use? So laparoscopic surgery, robotic surgery, when you're looking at margins and you're looking at surgical quality. This is a nice meta-analysis overview of margin positivity and muscularis propria, not complete mesorectal excisions in laparoscopic series. And what it shows is that there's no difference between the margin positivity at a very nice 7.9% and 6.1%, and muscularis propria down here at 13.2 and 10.4. So no difference between open and laparoscopic, which is as everybody would generally hold true these days. No survival differences either. If we go to robotic and we just have the results of the ROLAR study, which is the first international randomised trial of laparoscopic versus robotic, what you can see is margin involvement at 5.7%, so that's excellent, and you can see that between the arms there's no difference. And then the quality of surgery here is around about 75% mesorectal. So both in the laparoscopic and in the open, we're getting the same quality levels as we're seeing in the literature. So we can be certain that open, laparoscopic or robotic doesn't really make much difference. It's all about you. It's about you, the surgeon, and how good you are. And so that's what we really need to concentrate on going forward. When we look at radiology in the margins, Mercury 1 showed that we could accurately predict margin positivity by pathology with margin positivity with radiology. And we have the follow-up data published in JCO here, which is showing the relationships to outcomes in terms of overall survival, disease-free survival, and local recurrence, showing that actually radiology was quite good at predicting this. It's not quite as good as pathology, which makes me feel happy, but it's actually pretty good. So radiology is actually very good at defining margins preoperatively. So when we look at the rectal resections in 2017, I think we can say they can still be better. It's important to be done by high-volume specialist surgeons, and Denmark's a very nice exemplar of that. Excellent radiology is needed. Margin positivity should be around 5 to 10%, preferably now around about 5. At least 75% mesorectal, and no more than 10 to 15% muscularis propria. So I think these are fairly reasonable international standards, and photographs should be routine and used for quality control training, open, laparoscopic and robotic. And we've heard some discussion about the quality. Well, it's not about the pathologist. If you have the photograph, then you can have a discussion, a heated discussion perhaps, about the quality of the surgery. It is just a non-judgmental record of what you did. Whether it be rectum, low rectum or colon, if you've got the specimen photograph, you have the evidence about what went on. And then we can argue about whether you need 15 centimetres on the high tie or 5 centimetres is enough, or even 1 centimetre is enough. You can justify your surgery if you have the picture. If you don't have the picture, you don't have a leg to stand on. You need to have the pictures. So turning to the low rectal cancers, where we have much more of a problem, we've demonstrated way back that we had a worse survival in our abdominoperineals, and we learned about the planes from Torbjörn here, because he taught us about the extralevator planes, because he used to do this, whereas we never saw it. We saw this sort of stuff going on. Nick did the studies on the pathology of low rectal cancer and how much extra tissue we took out when we went wider, as Torbjörn told us to do. And then the RAD-PATH correlations came along with Gina, Nick and myself to inform where we were going. And Mercury 2 was funded by Pelican. Again, very grateful to Bill. We had interested teams. We wanted to reduce margin positivity from 30% in the low rectals to 15%. We had full protocols and 14 European centres, 21 radiologists and 26 pathologists. So a very big, multidisciplinary, trained trial. And out of that, in the Annals of Surgery in 2016, it showed that actually the margin positivity rate in the 0 to 6 centimetres, all the 0 to 6 centimetre tumours, including APs and ARs, 20% dropped to 8.7%. So we met that primary endpoint. Our abdominoperineals dropped from 30% down to 15%. So it showed that MRI-directed surgery actually achieved a lower margin positivity rate. Well, what were the outcomes? Please don't take photographs of this slide because it's not yet published, but it's here. Gina allows me to show it in small meetings like this, but it should be written up in the near future. And what have we got? Well, we've got very low recurrence rates. Here we got 3% at 2 years and 5% at 5 years, both in abdominoperineal and anterior resection. And look at the disease-free survivals, very good at 2 years, 75 and 77, and at 5 years, 61 and 66. So basically doing very well and having achieved the endpoints that we wished to achieve. And so that led to the low rectal cancer training program run by Brendan, everybody coming down to Basingstoke, learnt from Torbjörn. He came across from Proctored with Gina and Nick, and that led to lots and lots of training, which led on to lots and lots of training in Denmark with Soren, and lots of training around the world with Bill, Brendan and other people. So that sort of stuff has been translated around the world, and we're hoping to see drops in recurrence rates And when we look at the specimens before and after the training, we see big differences, and we see local surgeons in Yorkshire certainly dropping their margin positivity perforation rates and improving their local recurrences. So we think MRI-directed surgery has actually played a big role. And from the pathology point of view, what we want to see is appropriate surgery with the appropriate planes as determined by the MRI, and not these where you see margin involvement in very early tumours and big chunks not having been removed because of poor surgery. So it's appropriate surgery following the MRI-directed plane and giving us a specimen that is appropriate to the actual stage of the tumour. Now, I'm not going to talk a lot about histology. I've got just 2 slides. Firstly, to say everything we're looking at microscopically can potentially be seen macroscopically. And so the key features on radiology should be seen macroscopically. And if we do this properly, we get better sampling and therefore increase the rates. And you can see we can look for direct involvement, we can look for vascular invasion. These finger-like projections coming out from the muscularis propria have a high suspicion for those sorts of things. We can measure the extent of invasion outwards, we can look for peritoneal involvement and tumour deposits. So macroscopic assessment is extremely important, and that gives you your microscopy and enables you to raise the level of these features in your report. Histology factors we've talked about a bit already. In red are the ones which are included in TNM8 and DMMR should be included. These are the ones for the future. I haven't got time to go into all of these, but we've talked a bit about them. One factor that I think you ought to think about is the host factors. Again, I don't want to go into that. All I would just do is highlight neutrophil lymphocyte ratio. If you have high neutrophils and low lymphocytes, these patients do pretty badly and they have a higher rate of recurrence, a higher rate of infections. And we might be overlooking a really important factor that you get with a full blood count rather than having to spend $2,500 on a fancy RNA test or of some nature or an immunoscore. So please, I think we need to do more work on that moving forward. And so, so we need to bring this all together in the multidisciplinary team. If you don't know your margin involvement rates and you don't know your quality of surgery and you can't look at your pictures, you can't then have an informed debate about the risks to your patients of recurrence and how you should be treating them. So I think it's very important to bring it all together in an MDT, and we shy away from that because it's too embarrassing to have the conversation. But the photographs are the photographs. It's not the pathologist's interpretation. We can discuss the photographs and have a debate about why we think they're not quite so good and why you think they were perfect. That debate ought to be had in all situations. So in conclusion, excellent planar surgery is a key factor for all colorectal cancer surgery. It produces better planes and reduces margin positivity. And it's hands, it's laparoscopes, it's robots. They're all the same. It depends upon what's going on up here and the connectivity down into those tissues in the patient. Excellent radiology is important, and Mercury 1 and Mercury 2 and many other studies show that, but there are things that radiology can't do. Radiologists are not pathologists. They should be sticking at what they can identify, which is positive margins, depth of extramural spread, vascular invasion, and things of such nature. But one thing I do know is even in 2018, we can still do better. Now, lots of people contributed to that. We can't underestimate the impact of Bill and Pelican, of Gina, with the radiology of Torbjörn with the low rectal cancer, and some of the other people I've worked with. Thank you very much.
Thank you for this very interesting and very detailed presentation. Leaking out of the borders of classical pathology, but very interesting not only for the surgeons but also for us the pathologists. I think we have a few minutes for 1 or 2 opening questions.
If you want to catch up, it's not a problem.
Phil, do you think, based on biopsies, can you look into this ratio between neutrogen and lymphocytes and you know, in a simple way, maybe organize things.
Well, first thing to say, you may already have that data in your neutrophil lymphocyte ratio, because when we look at an NLR, and one of the young surgeons in Leeds did a study with us all, when you look at the NLR, so if you have high neutrophils and low lymphocytes, you had less lymphocytes in your tumour. And so we could actually do the comparison of a peripheral blood to the actual tumour. So it may be that NLR is what we should be looking at as an indicator of the patient's basic immunology.
Yeah, because then you would have some simple, you could say, predictors of how you should manage the tumors or the patient from the beginning.
I think we ought to be taking a lot more account of poor basic immunology in these patients in the same way we might do frailty.
Is the same ratio, NL ratio, in the peripheral blood and the tumor?
Yeah, so in the peripheral blood, you just count the neutrophils and you count the lymphocytes. You get it in a full blood count. For the tumours, we actually have to go in there and we actually have to count them, and that's not much fun. But when we do it, we can see that there is a strong association between the two. So NLR might give us a lot of valuable information. There's a lot in the literature about it, and it runs across all tumours. So it's not just bowel cancer. You'll see it in breast cancer and other things, that they have a higher infection rate and they have a higher level of recurrence. So I think we're missing a trick, and the other bits around that are measures of systemic inflammation, so C-reactive protein, higher ESRs. If you've got an inflammatory background in that individual, they don't do as well. Now, we don't understand it as much as we should, but I think we need more investigation. But at the moment, we just ignore it, and that seems a bit crazy given that there's a lot in the literature.